So I hope in the next 15, 20 minutes, I can help you understand a little bit more about biologics, or what you might hear out there, orthobiologics, and their use in orthopedics. I think orthopedics is a wonderful specialty. I think we're a group of people that are always looking forward and trying to push the envelope, try the next best thing. Sometimes we get ahead of ourselves, though, and there's history's replete with examples where we've almost direct to market or direct to consumer, direct to the surgeon, where we've started new techniques or new interventions before the data and the research has actually demonstrated its efficacy. And before I'm done here, I think I'm going to show you that what we know about biologics is very close I was trying to think of an analogy. And the only one that I could think of, if you imagine the first time a human saw fire, it's probably from lightning or something like that, and they're like, holy shit, right? There's this big bright thing. They probably didn't even know it was hot at that point. They just saw this big bright light, and it didn't go out. It got bigger, and it was destroying things. But that's all they knew. And then let's say 100 years later, they figure out, oh, we can control this. Actually, it can cook our food. It can keep me warm. Then they learned, well, it could burn down my house. And, then let's go another 1,000 years ahead and say, okay, now we know it's carcinogenic, depending on the product you're using. We know it has CO2. It's increasing greenhouse gases. So what we know about biologics is that oh shit moment of the Neanderthal. That's my comparison right now. And hopefully I can, in a more elegant way, will explain that to you here in the next few minutes. What are biologics? Well, again, that's a very broad term, and it's not a very good one, frankly, because biologics, when I was in my residency, referred to rheumatologic agents that had just come out to modify the evolution or the progression of rheumatoid disease. We called them biologics then, but they're now, is it DMARDs? Is that what it is? Yeah. So disease-modifying agents is what that kind of evolved to. So biologics in this sense really are referring to cells that we try to concentrate to use to our advantage in musculoskeletal tissue. In what ways? Well, we want to improve healing. So we want to improve the percentage or the likelihood that something's going to heal. Because what we do now, obviously it's never 100%. Well, if we can get closer to that number, that's helpful. Some cases in regeneration. So now we actually, on a Petri dish, we can make a tendon from a cell, from one cell, and make it looks like a tendon too. So that's actually really exciting. And then the quality of the tissue, because what you see here on this upper slide here is a picture of a native tendon bone interface. Okay, that's how it normally looks. I couldn't find one that's after a rotator cuff repair, but it doesn't look like that. It's basically scar. We've got tendon, scar, bone. It's not this native enthesis is the term that we use for it, but it never looks like that. And part of the goal is to get closer to that, if we can, with these cellular modifications or concentrations, if you will. So that's another goal. I had to put this up here. It's not really FDA limitations, it's more FDA guidelines, which is part of the reason we're here, and I'm talking about it, is because the FDA, while it has very rigid guidelines for some things, the manufacturers and the market has ways to find holes, if you will, in it, and bring things to market before we have any data about it. And so this is one of those instances, because if you have minimally manipulated tissue cells, there is very little, if any, FDA regulations. That's why PRP is out there. That's why you hear about stem cells. This is it. So what does that mean? Well, in the context of our discussion, it really means you're pulling whole blood from someone, and if it's PRP, or you take it out of someone's bone for stem cells, you put it in a centrifuge, you spin it down, and then you pull out a certain part of that that's been separated. You either add some solution to it or just add a little more volume to it, and then you insert it back. That's it. And because that's considered minimal manipulation, there's really no FDA regulation on it. So what are the potential biologics that we've probably all heard about? Some are being used every day, I guess is a way to say it. The PRP is readily available, and lots of physicians use it. No insurance pays for it. No insurance pays for any, well, the scaffolds we'll talk about later, but the stem cells and platelet-rich plasma, no insurance covers it, okay? The other ones, the stem cells I just mentioned, and I'll go through the three of them here and what the differentiation of them, and as I said, we'll finish up with the scaffolds. So platelet-rich plasma, what are the constituents of it? And you can kind of see the macroscopic view here of the red blood cells as they're separated out. They call this the buffy coat. I have no idea why, but that's the white blood cells. That's less than 1% of the whole volume. And then there's the plasma. Now we talk about platelet-rich plasma. You don't hear much about the leukocytes or the white blood cells or the red blood cells. And that's part of the problem here. As I go through the next few slides, there's no consensus as to whether it should just be plasma and platelets. Should you include leukocytes? Should you include red blood cells? Should there be less plasma, more plasma? And it'll become clearer as I go through as to why I have them all up there. What brought on this explosion, if you will, of interest in PRP? And it really has to do with growth factors. We know data done probably 40 years ago now, we started figuring out the growth factors that were involved in the healing process. So we said, oh, platelets have all of the growth factors, just about 6 of the 8 main growth factors that are in tendon bone healing. So that just became the gold rush, okay? Now they figured out how to concentrate the platelets. So again, we go back to the Cro-Magnon man. He sees this light, doesn't know what the hell it does, but we have these platelets. We really don't know how they work. We know they have these substances, but we don't know the concentrations, the timing, many different factors. How's it done? Well, we kind of went through that real quickly, but this is just another graphic display of it. It's actually a pretty simple process. We don't currently do this in our office for a couple reasons. I guess number one, it takes a fair amount of time. You have to sit the patient down, pull their blood, do the centrifuge, pull out the aliquot that you need, and then put it back in. The other thing is, I don't know, I think we're a group of people that we are kind of data driven, and if there really isn't any data out there that shows me that it's really efficacious, that we're not going to use it. And partly pragmatically is that it's a pain in the ass, frankly, and I don't like saying, well, insurance doesn't cover this, but if you give me $1,000, I'll inject this into your elbow. And that's essentially what's happening. I kind of touched on the fact that we know these growth factors are involved. We do know the sequence. You can't really read this, but what I'm trying to convey here to you is that it's not a simple process, okay? This is kind of a shotgun approach to delivering platelets to a site we want to heal. So there's different growth factors involved at different times. So we don't know, if we take our PRP and deliver it right at the time of injury, do we do it before surgery? Do we do it after surgery? That's one aspect of it. We don't know the half-life of these growth factors when we take them out of the body. We know the half-life when they're in your body. So when we deliver them, how do we know that we're giving them at the right time, and how do we know that they're able to act at the site when they're there before they're not worth anything? And then the delivery vehicle, that's thinking if you inject color dye into a glass of water, and you have this concentrated medicine, the blue dye, and it just diffuses out into the water. If you don't have a delivery vehicle with this PRP, it's just going to diffuse into the surrounding tissues. It doesn't stick around to where you want it. So there's different fibrin glues and collagen scaffoldings that we can use to deliver that, which isn't really the scope of what we're trying to talk about, but it is an issue, and one thing that we haven't fully tackled yet. So this slide comes from the Orthopedic Academy, and kind of outlines what their biggest concerns are from a consensus statement as to what can influence growth factors and how they present and how they act in this context of platelet-rich plasma. And I think I highlighted two here that I just thought were interesting and not necessarily totally, totally obvious, is that somebody on concurrent medications, if they're on NSAIDs, they're on anti-inflammatories, that's going to completely change their growth factor profile and other signaling cytokines and other proteins that they make. So it's just another thing that we have no control over right now and making no attempt to do so, but we're still using it. So what are the challenges? This is a slide to help you understand the nuances of all the different studies that are out on PRP. And it's basically showing a nomenclature that someone presented to try to tease apart all the different formulations of PRP out there, which is one of the big problems. There's no standardization in any of the studies out there as to what type of PRP you're using. So one will have leukocytes, that's the L, and platelet-rich or W-rich fibrin, in my case. This is pure platelet-rich fibrin. There's leukocyte and platelet-rich plasma, and there's pure platelet-rich plasma. There's really no way to tease apart the data that's out there right now to try to make sense of it. Because if it works in one study, but it's LPRF, but in PRP, it doesn't work, well, that doesn't mean it doesn't work. We just don't know why that one works and the other one does. So again, another confounding factor here as to why I think we're getting ahead of ourselves with PRP. Standardization of preparation is another issue. There are currently 17 different companies that make PRP. So there are 17 different ways to prepare it. That is almost impossible to do a study. You can't do 17 different studies. So part of the consensus statement was like, okay, we got to take a step back here. Let's try to, again, standardize so we can make sense out of what we're seeing. And I touched on this a little bit earlier. What about when do you give it? I showed you that slide with the growth factor. At 1 week, there's a list this long. So do we give it when there's a tendon injury right away when they're in the ER? Or do you wait because it's maybe better to augment the response at 3 weeks? Maybe that's a relatively higher risk area for non-healing. We don't know the answer. And this just demonstrates, do we give it during surgery? That's where a lot of studies have done it. Or do we give it when they're in PT? Maybe it's better once they're starting to mobilize. The neovascularization around the tendon's better. Maybe we need to do it then. We don't know. So here's some of the data we do have in a one-slide synopsis. There are approximately, again, this is just rotator cuff. There's elbow, knee, any joint, you name it, it's out there. But for the shoulders, about 20 studies. When we look at patient-reported outcomes, and that's, you ask the patient to fill the data out and say, can you throw a ball? Can you lift this? Can you reach your arm behind your back? There's no difference in the outcomes when you look at PRP repairs and non-PRP repairs. It's not good. But there is a trend, I would tell you, that would say when you look at an ultrasound or an MRI, that the healing rate's probably better. And that has more to do with our lack of understanding about rotator cuff function, because we've known that for decades, that people can do really well after surgery, even if the rotator cuff doesn't heal completely. So it's not so much probably about the PRP as it is the natural history of what the rotator cuff does. This slide just gives us a synopsis about the elbow. This is the one area, and perhaps it might work. There's been 2 or 3 good meta-analyses of all the data, which is not a great way to do it, but is really the only way we have to kind of make sense of it right now. But it may help. But I would tell you as an aside, this sentence here is pretty important. Our approach to lateral epicondylitis has changed dramatically. I used to do a fair amount of surgery for lateral epicondylitis. I maybe do 1 a year now, because what is felt now that this is a process that probably everybody in this room will get. You may get it for just a day. You just touch your elbow and it's gone the next day. I have people that have had it for a year and a half. But ultimately, it goes away. That's the bottom line. And there's no danger of your tendon ripping, tearing, or breaking. This is something that's really a paradigm shift just for one diagnosis, but it's really a shift away from surgical treatment and really away from anything invasive. You don't need to put a needle through the skin to treat this, be it cortisone, PRP, or otherwise. Cortisone is actually found in at least one study to help you short term, but probably prolongs your total healing time. So you think about that. That's a hard sell though, because we're all like instant gratification. So I still have patients say, I don't care, give me that damn cortisone, I want to feel better. Even though I tell them, you may be done with your symptoms in 3 months if you don't do anything, but you can lead a horse to water. All right, we'll move on to stem cells. So this is Dolly. I don't know if you guys remember Dolly. I think it was the early 2000s that they first cloned an organism. So Dolly is an example of using totipotent stem cells. I'll go through this quickly because it's not really relevant. Totipotent stem cells are where all the controversy surrounds this because you have to procure embryos, which is ethically a big, big conundrum. Also, which is not talked about as much, is the tumorigenic potential of embryos in this context. And it's actually been shown in animal models that their rates of neoplasia are much higher, as well as teratomas. Pluripotent stem cells are like the next level down. Pluripotent stem cells can make every cell type in your body except making another person. That's only what totipotent can do. Pluripotent stem cells are from about after the second or third cell division to 8 weeks of development. These also have the same concerns because you can't get pluripotent stem cells unless you pull them out of an embryo that's still in the totipotence phase. So we're going to focus on the multipotent stem cells, which also have the term adult stem cells, which you may see out there in some of the literature. And this is really the focus of how we're using stem cells today, and probably will be in the future just because of the ethical, legal concerns. So this is a blow up of that last slide. And so the term that is used for stem cells that have the ability to evolve into musculoskeletal tissue are called mesenchymal stem cells. And we can get those from 3 main sources. There are a couple more, but these are the main ones that you'll probably read about and are available. Mesenchymal stem cells, again, it's tendon, nerve, bone, ligament, anything in the musculoskeletal system and ectoderm as well, it can develop into. We'll go through the 3 of these. I'll go quickly through the amniotic and placental derived. There are very few human studies, and it's really using human amniotic membrane, which is up here. It's commercially available. It's used in burn victims. It's used around, there's a study in the podiatric literature that uses it to help reduce tendinous adhesions. But it's really an avascular, basically making beef jerky out of that layer of tissue. It's an avascular cellular layer. So it really doesn't have the true stem cell qualities as we think about it. We don't think anyway. There is one rabbit study actually using umbilical cord blood-derived MSCs out there, which is promising. But again, it's on a rabbit and there's only one. So we're a long way away from using this. Oh, and this is an awful slide, I apologize. These are the 5 studies that exist today on amniotic-derived MSCs, and none of them are in humans. 3 of them are on the Petri dish, and 2 are animal. So we'll move on to adipose-derived stem cells. One nice thing, it's readily available on all of us, probably too much, but it is a source that, again, internally is available. A nice thing about it as well is has this decreased immunogenic potential, meaning the likelihood that you have a cell versus non-self response is decreased. So its potential as an allograft source of cells is good too, which is not the same for all stem cells. And this higher CFU means the colony-forming mutants. So if we ever got to the point where we were culturing these to grow the numbers, they basically grow better than the next set of cells I'm going to show you. But as to date, there are currently no human studies in this. It's all animal. Then finally on to the last one here, and this is where, you know, I see it every week in the Duxbury Clipper. There's an ad for a doctor that is giving stem cells. He's going to help you with your arthritis. These stem cells are taken directly from the bone marrow. The most common site is your iliac crest, but it's been found in any extremity bone. Relevant to the shoulder, obviously, the proximal humerus. There is a study that demonstrated that you can remove them and concentrate them. To date, there are 20 plus animal studies with promising results. That's about all you can really say. The 7 human studies are not great. I was actually really surprised. They were really most of them were from low quality journals. And the primary technique to do this is microfracture, where you just put holes in the bone and let the marrow come out. And that's really kind of silly, frankly, and I'll show you why in a second. So there's very little data here. 2 of these studies did pull out the cells and spin them down, but the number of cells in that concentrate is less than 1% of the entire volume, which is felt to be almost worthless. Here's that slide again. So we don't know how much you need. Is 1% enough? Is that actually going to enhance the local environment to create a better healing, that instead of scar, that's a real bone tendon junction? What mixture of cells are needed? What that means is there's some data to suggest if you clean the cells of any endothelial cells, fibroblasts, other heterogeneous cells, it may be better, but there's other data that says you should keep them all together because we still are like that Cro-Magnon man. We don't know the interactions between other cells. And then importantly, we don't know the interactions of the 1,500 cytokines that are involved at the healing site. So again, we're very early in our understanding of this. One slide here, we're almost done, I promise. Scaffolds. So you have the porcine xenograft that was available almost 30 years ago. And it has been used in the shoulder with very limited, not even limited, actually not good results. It's not used in the shoulder anymore because of that. Had an awful inflammatory reaction in about 40% of the patients. It looked like they had an infection, but it was just this immunogenic response to this foreign tissue. Surprisingly, though, it does work well in other applications in general surgery and burn patients, but just not in the shoulder. Collagen allograft, I do use this in my practice in revision cases. It's a salvage operation. It's human collagen that's been cleaned and processed. It does provide a level, it's almost like leather, but it provides a linkage in really challenging cases that otherwise you don't have an option. So in closing, I'll tell you, there's a difference in perception and reality. I think sometimes we as physicians think we're in the lab and we're doing this high-tech work and we're ready to go and push it out there and save lives, when in reality, we're more like Australopithecus here. No offense, Eric, but we have a long way to go before we really figure out how to use this technology in a safe, efficacious way. Thank you.